A very good evening to all my dear students. So, how are you all? Doing well? So, a lot of panic around next exam? Huh? No need to panic. No need to panic at all. Everything is same. The subject is same. The information is same. The only thing that changes is how we are going to practice the questions and how we are going to answer, right? So let me first be very clear to you all that the purpose of this session, why I'm sitting today in front of you all, is to give an idea about in ophthalmology what is next all about, what are the clinical questions, and how it is going to really help you if you follow the question back, right? So when we are going to solve these questions, you will be amazed to realize this, that okay, I know everything. It is only the style which is different. It is only the way which is different. Rest, everything is okay. We are learning in the lectures. We are learning in our video lectures. All the details and everything is there. So please, first of all, don't panic at all. Okay? Yeah. So let us start with the discussion. Let me see. Yes, a very good evening to all of you. So let's start with the discussion. What next, right? Let's see. I'll start with question number 1. So how we are going to go about here is we will read the question and then we are going to go together by marking the important. How do we solve these questions? Let's see. I'm starting with the first one. A 30 years old female presents with complaints of blurring of vision while reading and photophobia in the bright light. ठीक है, ध्यान से पढ़ते रहो. On examination, there is anisocoria. We all know what is anisocoria, difference of pupil size, with a large regular pupil in the left eye. Right? Both direct and consensual light reflex is absent in the left eye. The left pupil responds slowly to near with slow redilatation. Right eye shows normal pupillary response. Fundus is normal in both eyes. The most likely diagnosis. So first of all, so much of information. The first thing that happens to you all is panic. Arey baap re, how to solve this question? Isn't it? Let me give you a few tips here. You will never feel any fear in solving these questions. Read the last line. Read the options. That is the first step. What is the last line? The most likely diagnosis is. They are asking you the diagnosis. I am asking these are questions, so I am asking you the diagnosis. And what are these options here? Acha, theek hai. Quickly look at the options. That is your second step. See, this time in this session, I am going very slow to explain you how to solve the clinical questions and how to go about the next exam. So when you look at these options, you see, acha, ye to different types of abnormal pupillary reactions hai. Isn't it? Okay, so now your mind is oriented towards this, that you need an answer around it. So what did I tell you? First read the last line, then what it is asking, read the options, you will have the idea. Now go back to the question and read again. Now what are the important points we have to note down in this question? Let's see. A first important thing is 30-year-old female, okay, young female, complaining of blurring of vision while reading and photophobia in the light. So this is another important thing. Reading में blurring हो रहा है with photophobia and there is anisocoria. If you have really attended my lectures well, you will realize I have taught you so many times that when you say anisocoria, it is mainly the abnormality of the efferent pathway. Large regular pupil in the left eye. So left eye, there is a mid-dilated pupil. Okay? So I think you already got an idea which abnormal pupillary reaction. Can you all give me the answer? Can you all give me the answer? Okay. Yashwant, think again. It says both direct and light reflex is absent. वो तो ठीक है. The left pupil responds slowly to near with slow redilatation. Tonic pupil. Isn't it? So, and of course the other eye response is normal and the fundus in the both eyes are normal. So, अब क्या diagnosis हुई बताओ? What should be your answer? Tell me. What should be your answer now? Yes, Kamal, please keep listening. ठीक है, it's a matter of, it's a quick session and it will always help you in revision and help you to revise a few very important things. If you want to, you can sit and listen. So again, see, you all are not able to answer this. You know why? Because the question is absolutely very simple. Whereas the trick is the options also, na? The options can make the question little difficult, isn't it? Look at the options again. Why are you saying B? Then you all are saying A. What is Argyll-Robertson pupil, guys? It is absent light reflex and near reflex is present, isn't it? It is due to the lesion in the pretectal nucleus. Acha, what is the position of Argyll-Robertson? वो तो छोड़ो. Argyll-Robertson में we all know both eye is miotic pupil. So is this the answer? No, it is not the answer. We are talking about mid-dilated pupil. We are talking about tonicity. So what should I search for? Can any one of you tell me what should I search for? With this type of history, can you name what is the abnormal pupillary reaction I should be looking for? Chalo, batao. Acha. So now you say that it is C. Nahid? Afferent pupillary defect. But it is not an afferent pupillary defect. Anisocoria occurs when there is a defect in the efferent pathway. Isn't it? When there is a defect in efferent pathway means third nerve. Sabko yaad hai na? Pupillary light reflex. That is the third, it starts from the third nerve. Efferent I am only talking about. It will start from third nerve. Then it is going to go to inferior division of third nerve, nerve to inferior oblique, ciliary ganglion, short ciliary nerves. याद आ रहा है? तो बताओ अब क्या आंसर करना है इसमें? I'm giving all the time here because I want you all to think and then we rush to the next question. So we again go for पढ़ा है हम लोग ने young middle aged female है with a unilateral mid dilated pupil with tonic pupil, ठीक है, and light reflex is all absent but near reflex present. अब बताओ क्या है ये? This is Holmes-Addy, guys. You have to revise properly. It is Holmes-Addy pupil. This is what is called tonic pupil. ठीक है? Holmes-Addy is more common in middle-aged females. ठीक है? तो यहाँ पे हमारा आंसर क्या हो जाएगा? None. कभी कभी आंसर none of the above भी तो हो सकता है ना? So we can have this answer as well. So here our answer will be none of the above. Let us revise because you all have not answered in a very good way. I am not very impressed here. So we'll quickly revise. What was Holmes-Addy? So Holmes-Addy pupil is when there is a lesion in the ciliary ganglion and short ciliary nerves, right? So everybody remembers this, the pathway of pupillary light reflex pathway. Do you all remember the pupillary light reflex pathway? It starts from, okay, let me explain that also. If you take this as a visual pathway, a very, very simplified depiction here. ये हो गया left retina, this is right retina, equally divided into nasal, temporal, nasal, temporal. Temporal, nasal fibers will decussate, temporal does not decussate. Everybody knows I am talking till here about the visual pathway. अब ये हो गया optic nerve, this is optic chiasma, optic tract. यहाँ से it is not going to go further down but it is going to turn to pretectal nucleus and this pretectal nucleus finally innervates both Edinger-Westphal nucleus. Everybody remembers now? And because every pretectal innervates both Edinger-Westphal nucleus, this is the reason why you get a consensual light reflex. Even if you are showing light in one eye, you are seeing that both the pupils are constricted. ठीक है? समझ आ गया? So this is your afferent pathway. ये हो गया आपका afferent pathway. Right? Okay, now we talk about efferent पे आ जाओ जरा. What happens after Edinger-Westphal? After Edinger-Westphal, it goes to the third nerve. From there, it will go to inferior division of third nerve. Right? From there, We all know, no? Third nerve has two divisions, superior and inferior. It goes to nerve to inferior oblique. From there, ciliary ganglion, and lastly, short ciliary nerves, and finally, iris sphincter. So that was a quick revision about the light reflex pathway. Now revise with me. Any lesion which is happening at the efferent part of pretectal at this level will lead to ARP. Argyll-Robertson pupil. What is Argyll-Robertson pupil? Here you can see it is not reacting to light, but it is reacting to accommodation. This is what is Argyll-Robertson pupil. Light reflex absent and near reflex present. Right? और यहाँ पे देख के बताओ. This is your Holmes ID. What it is showing, ध्यान से let's understand this. When I am showing the light, okay, so no reaction. Light reflex, it can be very sluggish also or no reaction. And when you are showing a near object, yes, accommodation reflex is present, but it is slow. And when even you remove the finger, this has not gone back to dilatation. Redilatation is slow. It is tonic. This is Holmes ID. Holmes ID will happen because of the lesion of ciliary ganglion. Short ciliary nerves will lead to Holmes ID. So efferent pathway के lesion से Holmes ID. ठीक है? I hope now it is absolutely clear. Your concepts will see whenever you have to answer on pupillary reactions, you have to go back to your pathway. You will answer everything. Just be clear about your pathway. That is very important. ठीक है? चलो अब आगे पढ़ते हैं. ये we are now clear about Holmes ID, present generally a middle-aged female presenting as a mid-dilated pupil. We talked about this. How do we test Holmes ID, right? We talked about pathway. This is Argyll-Robertson. What is the next pupillary abnormal pupillary reaction is Horner's syndrome. Now this I think everybody knows. It is due to lesion of sympathetic chain. A quick revision here. So this is due to lesion of sympathetic chain, isn't it? And of course, how will it present? Meiotic pupil, which is staying meiotic even in the dark. Actually, there is a dilatation lag. It will take a lot of time and it may a little bit dilate, but I don't want to complicate, especially for FMG. Just remember this. If FMG people are sitting, just remember this. What is Horner's? It is lesion of the sympathetic chain and characterized by ptosis, meiosis. So all of you, next people, you all should know this. This was exam question. Ptosis, meiosis, what else? Enophthalmos, anhidrosis, and loss of ciliospinal reflex. Loss of ciliospinal reflex. हो गया? ठीक है? So the question of the exam was that Horner's can be described by which two features. So what you will answer? Mainly we have to answer ptosis and meiosis. So at this point I am not going in too many details of every condition. I am just giving you a quick reaction. Now when I look at one, okay, there's a constriction. This is normal. So initially I may get a normal response. अब हम इसको बार-बार, I repeat the whole process again and again. So I again get constriction, dilatation. So when I am getting dilatation with a direct light, so direct light में अगर direct light से dilatation, it's absolutely abnormal. How could I catch hold of this? Only when I started comparing again and again. Therefore, it is called relative afferent pupillary defect. What else do you call it? We call it Marcus gun pupil. What happened? Some problem with the net? Tell me quickly. ठीक है? Can we go ahead? Okay, you want me to repeat from Horner's syndrome. Acha. Okay, very quick. Here what we said that Horner's is nothing but lesion of the sympathetic chain. You can just rewind it and see it also here on a YouTube. Huh? Then what are the features? It is ptosis, meiosis, enophthalmos, anhidrosis, and loss of ciliospinal reflex. Okay? So when you say there was one question I just said that what are the two main features by which you describe a Horner syndrome? Among the all, you have to answer ptosis and meiosis. I am not taking it in detail. I'm just going for a quick revision, as I said. And of course, one eye it will show as meiotic pupil, which is not dilating or taking lot of time to dilate and light in the dark. That is what is called dilatation lag. Okay. Chalo, ye tha Horner's because, oh, okay, great. Then next we talked about was swinging flashlight test. This is what you're looking at is relative afferent pupillary defect or swinging flashlight test. So when you say swinging flashlight test, I was explaining you all that how we test and what is this? It is the first sign of optic nerve disease. Okay, so already done, just ek baar dekh lena. We'll go further, we can't waste time here. So this is the first sign of optic nerve disease. What is the other name? We call it Marcus Gunn pupil. It is called Marcus Gunn pupil. It is the first sign of optic nerve disease. Ab to theek hai? Yes, Tanay, it is seen in Pancoast tumor. Just revise the pathway of the sympathetic chain because it is going through the apex of the lung. Any Pancoast tumor will affect the sympathetic chain and can lead to Horner's. Chalo, next padhte hain. Okay, now I want again all the concentration. Please challenge yourself to answer these questions. Again, this is the next pattern. This is how they will give you the question. Please don't get intimidated with a paragraph jaisa question, okay? What we need to know is काम की चीज क्या लिखी है. What is the main point that we have to look at? What did I tell you? We will first read the question together. A 50 years old male patient presented to the emergency department with persistent fever, cough and worsening shortness of breath, tested positive for COVID-19. He had fever of 101.2 Fahrenheit, tachypnea and bilateral expiratory wheeze. Chest radiography revealed bilateral reticular interstitial opacities consistent with viral pneumonia. So it's just to stress you out, बहुत कुछ और detail दिया है, okay? On the day of his discharge, on the 12th day, he complained of sudden onset of loss of vision in the right eye. Now pay attention. On examination, right eye pupillary reactions were absent. Okay, so right eye on examination, pupillary reactions were absent. There is a sudden onset in the right eye. So what have you answered? On rest of the anterior segment was normal. Dhyan se sunte raho. First listen. On fundus examination, retinal whitening with red spot at macula. Okay, our optic nerve has slightly indistinct margin, the most probable diagnosis. What did I tell you? How will you solve this? I will read the last line and the options first. So it says diagnosis and macular hole, optic atrophy, arterial occlusion, cortical blindness. So now my mind has to go between neuroophtha and fundus only. Isn't it clear? Go back to the question. So what is the main point? He is a tested COVID positive patient. Quickly it should come to your mind. What are the features in COVID positive? What are the eye manifestations? One is what is the most common manifestation? Do you all remember? Most common is mainly follicular conjunctivitis. Apart from that, which is the serious one? What it can cause in the eye? That is your CRAO, central retinal artery occlusion. So this is what? See, I have deliberately removed the word cherry red spot, okay, just to give you some idea that how the questions can be made little more difficult. Okay, so this is retinal widening with a red spot and macula is nothing but cherry red spot. Naturally, answer will be arterial occlusion. I am talking about central retinal artery occlusion. We will not forget in COVID the two eye manifestations. One is your follicular conjunctivitis and second is your central CRAO, central retinal artery occlusion. So naturally this patient with sudden loss of vision ho rahi hai, na? And pupillary reactions are absent. So it has to be CRAO. Easy? Very good. Then we talk about a few quick things. See, this is what the picture of a cherry red spot, and it is very important for both exams. I think this is a very common image that is asked again and again. We are looking here at cherry red spot. Okay, I'm going to be a little quicker now because details in neuroophthalmology take little time, but I think this is done. And what else they ask you in, I'll discuss the questions in CRAO apart from cherry red spot. Acha, before that, what are the causes of cherry red spot? Ek baar ye bhi quickly revise karo. One is your blunt trauma, that is Berlin's edema, right? Second हो गया आपका, you can say is CRAO. And what should you write third? Third is your depositions. I just call it depositions. We mean sphingolipidosis, gangliocytosis, है ना? Tay-Sachs disease, Niemann-Pick, Gauchers, even send-offs, okay, Krabbe's, everything comes under this as a cause of cherry red spot. Second question they will ask you is, even if there is a central retinal artery occlusion, the patient is not blind. In that case, what is the finding? This is happening because this patient has a cilioretinal artery. This is the next question they ask you regarding this topic. Cilioretinal artery is a branch of, it is a branch of short posterior ciliary artery. Okay? And with this cilioretinal artery, you see that some part of the macula, central macula, and little bit of field is left behind. And therefore, any CRAO with cilioretinal artery is a cause of tunnel vision. ठीक है? और क्या पढ़ा था tunnel vision के causes? Apart from this, it can be, as you remember, bilateral occipital lobe lesion where both sided posterior cerebral artery blockage is there. Late stage of retinitis pigmentosa. What else? Then what are the drugs? Vigabatrin. This is a quick revision. Or quinine. These are causes of tunnel vision. Okay? I said other causes. Again, I am repeating. Late stage of retinitis pigmentosa. And I said bilateral occipital lobe lesion where both side posterior cerebral artery is blocked. और क्या पूछेगा? आपसे पूछेगा, okay, CRAO is an ocular emergency. How quickly you should be able to open, if possible, you can resume the patency of the central retinal artery. What is the time that you have? Is only 90 minutes. This is another important question. If you can revive this patient within 90 minutes, he may regain his vision, otherwise it is permanently gone. There will be irreversible damage to the macula. Acha, Shreya, about glaucoma na, thoda sa, this is really controversial. You can say debatable bolte hain, more positive way to say it. Why debatable? Because see, many sources say glaucoma can be a cause of tunnel vision. हम लोग उसको एकदम last में लिखेंगे. Reason because why we are not, I am not preferring to write here. Because the last field that is left, the island of vision that is left, you have learned with me, is temporal island of vision, not central island. Okay, so it cannot be a cause. That means when there was a central island of vision, there was temporal island of vision as well. So that cannot be purely a tunnel vision. But yes, in many sources, we do mention glaucoma as a cause of tunnel vision. Okay, yeah. ठीक है Shreya? Okay, I want you to see this also. How will a central retinal artery on angiography? Because see, the central artery is all blocked. So see, you don't see any dye in these vessels, right? And there is a late filling because short posterior ciliary artery is fine. So you can see the dye there, but you may not see the dye here, right? Okay. Then we talk about is next question. So these were the quick questions on CRAO, tunnel vision, cilioretinal artery. I hope you have revised with me. Chalo, how to solve the next question? Again, don't get intimidated with the size of the question. Let's read it. Quickly, pehle kya dekhenge? Let's start applying. Kya dekhenge? Options dekhenge and the last line. What was the last line? The lesion is in. Okay, where is the lesion in? What is the? So we have to think on the neuro of that term: optic nerve, optic radiation, optic tract, chiasma. We have to find the site of lesion. Okay, now let's read the question. Once we read the question, we are going to mark the important point here. A middle-aged woman, I will mark this, presented with complaints of painless diminution of central vision in her left eye detected on routine examination. Okay. She also complains of difficulty in reading. On examination, visual acuity left eye mein 6/24 ho gayi hai. Right is also not that good, but maybe it could be refractive also, or there is some problem. Intraocular pressures 12 and 30. Pupils show brisk reaction in right, whereas left eye shows mild. So we are talking about left eye, diminution of the vision in the left eye. Now we are saying left eye mild RAPD, mild lenticular changes in both eyes. Visual field examination shows, this is important, pay attention, centrocecal scotoma in the left and superotemporal field or respecting the vertical meridian in the right eye. एक आई में सेंट्रल स्कोटोमा, अदर आई superotemporal quadrantopia. I think this should be diagnostic. And so what have you answered? You all are not answering correctly. Fundus shows temporal pallor in both eyes with normal macula. And look at the MRI, cellular mass, snowman appearance. Go to your radiology. Now you should get an idea, where do you get this? Pituitary adenomas, what are they going to really affect? Chiasma. Huh? So what are we talking about is junctional scotoma of trachea. If you look here, if the lesion is exactly at the decussation of two nasal fibers in the chiasma, ये अगर lesion है, so what you are getting? Both nasal fibers gone, so you get a both temporal field is gone. ये भी गया, ये भी गया. The shaded part is the one which is gone. Hence we call it bitemporal hemianopia. Now come to related to this question, this is what is happening. What is happening? The lesion is at the junction of optic nerve and chiasma. And this is what is called anterior junction syndrome, or we call it junctional scotoma of trachea. We can call it junctional scotoma of trachea. ठीक है? अब इसमें क्या हो रहा है? I hope you all remember this, that it is nothing but the inferonasal fibers which detour to the opposite side as Willebrand's knee. यहाँ पे lesion है, so these inferonasal fibers are gone. Therefore, on the opposite side, I will get, everybody knows field is opposite to anatomy, inferonasal fibers, so you get a superotemporal quadrantopia. ठीक है? So what I am going to get here is this central scotoma and superotemporal quadrantopia. Yes, Shubham, Willebrand knee is affected. Willebrand knee is nothing but it is the inferonasal fibers which detour to the opposite side in the chiasma and then go down and then cross. Right? So what is the answer? It is D, that is chiasma. Okay? Easy? So everybody remembers this? Now we know this is central lesion leading to bitemporal hemianopia. Then we talked about anterior lesion leading to anterior junction syndrome because of the involvement of Willebrand's knee. Acha, let me tell you one more thing here. Sometimes you can also get a presentation where it is not centroscotoma but pura ka pura chala gaya. One side blindness, another side superotemporal quadrantopia. This is also called the same, and this can also happen. So if it's a partial lesion, it can only lead to centroscotoma, but sometimes the whole optic nerve is involved, so it will lead to everything is gone, that is ipsilateral blindness. So either of the finding is included in anterior junction syndrome. अच्छा, अब उसके बाद what is posterior junction syndrome? We should also know that these are mainly macular fibers. तो posterior junction syndrome क्या होता है? When only macular fibers are involved, but that is also heteronymous. ठीक है? One of this side, one of this side. So macular heteronymous hemianopia. ठीक है? It is macular but heteronymous, not homonymous. Heteronymous hemianopia. One on the left, one on the right becomes heteronymous. This is what is called posterior junction syndrome. So if you realize, we have learned everything. The question that is asked is just elaborating things so that you are more acclimatized to how you have to think in that patient. अच्छा, एक और tip देते हैं. I'll just give one more tip here. Whenever you are learning or reading a ophtha question, I see this is how I teach you, na? Generally, if you remember, we generally make a diagram here, start thinking outside to in, what happens here, what happens here, so all these ocular findings that is described in this question is describing according to this diagram. If you can just keep that in mind, it will become very easy for you, right? Okay. I'm trying to make it as simple. I really am trying to make an effort to remove that panic from your mind and just be confident. Everything is same. You can do it. You have to just practice differently, right? Yeah. Question practice has to be absolutely in a different way. Okay, we come to the next one. Let's see what this question says. So 45 years, so quickly what should I do? What did I tell you? How will I solve this? I will quickly look at the last line. Which of the following condition is most likely present? Quickly, I am going to first look at the options so that I can think in that line. Okay, primary angle closure suspect, angle closure, acute primary angle. They are asking you what is this question all about? Stages of angle closure glaucoma. So now I will read the question. A 45-year-old patient, okay, presents with ocular discomfort and intermittent episodes of mild eye pain. On examination, the patient has shallow anterior chamber, narrow angles. Okay. Intraocular pressure is within normal range. So when intraocular pressures are still within normal range, okay, and there is intermittent episode, we are talking about this. What was the earlier classification saying? It is stage of what do you call it? Instability. But now we call that, we have changed the name, we call it primary angle closure suspect. Okay, this is classification of angle closure glaucoma according to natural history. So classification according to natural history. Please revise this yourself. Kya tha ye? All of you? First was suspect. In suspect, how do you define? When it just has occludable angles. What are occludable angles? When there is a iridotrabecular contact in more than 3 quadrants. 3 or more than 3 quadrants. Okay, this is what is called with normal intraocular pressures. This is your suspect. That means the whole classification is quite based on gonioscopic findings, isn't it? There is no posterior peripheral anterior synechia when we talk about this stage. Then comes the next stage. This next stage mein kya hoga? You will get all these findings, but along with that, how to learn it? If you want to learn here with me, learn it. All the finding means you are getting the iridotrabecular contact in more than 3 quadrants. This time IOP is raised, okay? And this time I may get a peripheral anterior synechia. This becomes the next stage, angle closure. But here again, fundus is normal, nerve mein koi changes nahi, there is no damage in the nerve, fundus is normal. Now when we come to angle closure glaucoma, this is the stage, all these features plus optic neuropathy, optic nerve changes, this is what is called primary angle closure glaucoma. Easy ho gaya? So, kya kya pada? ITC of more than equal to 3 quadrant. Again a lag, I don't think my net is fine now. Yes, Deva. So, you're right. I'm just looking at what you just wrote. Correct. What you just said, right? Okay? So, this is how very quickly we learn the classification. Beach mein, what is this stage? Just remember, this is the same that you have learned, acute congestive glaucoma wala stage where all 360-degree angle is closed, hai na? And IOP rises up to 60, there's corneal edema, it's a painful red eye. That is what is acute primary angle closure. Which earlier, what do you used to call it? Acute congestive glaucoma. इसी को बुलाते थे acute congestive glaucoma. So that was the classification, and this is how you're going to solve this question. We come to the next question. Okay, it's fine. Thank you. Okay, we come to the next question. Again, we will not be intimidated with the whole thing. Last line padhenge, options padhenge. Field testing shows the relatives the most probable diagnosis. Okay, so we have to think something in lines of retina. That gives me a quick idea looking at the option. I go back to my question now. So a 35-year-old man, okay. So everything, always the age and gender is important, okay. It gives you some idea. With a blurry vision is the complaint since 1 week, okay, only 1 week. The images in the right eye, so the problem is in the right and images were distorted. What do you call distorted image? Metamorphopsia. Don't forget that. He noticed his symptoms several days after starting oral steroids for arthritis. Now you can appreciate this history only when you know that CSR is aggravated by steroids. Now there is no history of floaters or photopsia. If there is no history of floater and photopsia, it indicates no, generally not towards retinal detachment. Okay. No history of diabetes and hypertension. Okay, the message taken on examination. So no history of hypertension, diabetes also helps you to come to the point that no, we don't have to think in the terms of diabetic retinopathy or hypertensive retinopathy. Right? Again, you all are answering wrong. Reconsider what you are answering. So, you know, let me confess, I've deliberately taken a very smarter questions. I've made myself just twisted the questions and the options. So you all are getting trapped in it, but it's very simple. This I wanted to do to expose you कि बस इससे ऊपर कुछ ज़्यादा कुछ ऐसा नहीं आए. Okay. So anyway, so steroids for arthritis in his wrist. हो गया? No history of lotus photopsia, no history of DM. Let's keep reading the question before answering. On examination, visual acuity in the right eye was blurry vision. Vision is little less. IOP is normal, so generally not related to the pressures. Pupils round reacting. Okay, very important information. When we look at the slit lamp, both eye anterior segment is normal. Stop thinking about it. We have already stopped thinking about anterior segment because I am looking at the options as there's something in the retina, we know that. है ना? तो ये anterior segment is normal. On fundus examination comes the diagnostic point, ring reflex at the foveal area. अब बताओ, why not foveal detachment? Yes, Deva, very good. What is foveal detachment? CSR is nothing but a shallow retinal detachment at the fovea, na? So you should be choosing this as the option. So ring reflex at the foveal area. Fundus rest is left eye ka to normal hai. See, it is again telling you Amsler grid test shows distortion. So Amsler grid test is showing you the metamorphopsia that you see on Amsler grid. You remember this? So, field testing showed a relative central scotoma. Relative central scotoma. You all remember what is relative and what is absolute? Huh? In any situation, if the scotoma persists, it is absolute. Blind spot is an absolute scotoma. But when you change the illumination of pupil size or some conditions are changed and you can still see, sometimes not, that becomes relative. Anyway, therefore, our answer is, what are the diagnostic points? He is a young male. We all know CSR is common male is to female ratio. Please note down is 3:1. Don't think it never happens in females, but yes, generally it is the disease of young males. दूसरी चीज, distorted. So metamorphopsia, mild diminution of vision, not much. History of steroids intake, ring reflex, Amsler grid is showing the finding. Everything goes towards central serous retinopathy. Okay, what are the other questions in central serous? Where is the fluid accumulation? I hope you all know this. We are talking about subretinal space. So if you're not clear with subretinal, I would just request you to watch my previous sessions, please. Everything in detail about the retinal anatomy and has been explained. You will know what is subretinal space. It is due to, next question, breaking of outer blood retinal barrier. What is outer blood retinal barrier? When there is a strong adhesion between the RP cells, that is called, that is the outer retina. When that is broken, there is leakage from the choroid into the subretinal space. What is the next question? It is this. It shows as ring reflex. So this is what is ring reflex, which is nothing but a shallow retinal detachment की वजह से your light of your ophthalmoscope encircles that detached retina. और उसी को बुलाते हैं ring reflex. Right? So that is what is ring reflex. Yes. And then next, see, this is what is metamorphopsia, right? You can see the blue arrow, this is on Amsler grid, this is what a normal person will see something like this. Amsler grid tells you how much of the field, 20 degrees. It corresponds to macular area. 20 degree of visual field is depicted by Amsler grid. Yaad rakhna hai, right? Okay, we come to the next. Another finding of CSR asked in the exam is the OCT. Again, this is the retinal pigment epithelium. This time I have not taken the colored one, just to give you an idea that you may come across this one as well. And this is all your neurosensory retina. So it's a retinal detachment, but it's only at the foveal area. It's a foveal detachment. So we are talking about CSR. ठीक है? Okay. अब देखो यहाँ पे क्या दिख रहा है? Because of this, this is so many times they have asked you a question. I put a double Q when it is a repeated question. This is your ink blot pattern. Ink, this is seen on angiography. So fluorescein angiography finding ink blot pattern. And this is your smokestack pattern in a mushroom shaped manner. Both are repeated questions. Yes, Tabish, please keep listening. Chalo, we come to the next question now. Again, first of all, I will look at the last line and the option. What is the likely diagnosis? Okay, I am talking about like trimal drainage system. I have to choose between acute, chronic, canaliculitis, dacrocystosine. Once you keep this in mind, start reading the question. 55-year-old male presents with a sudden onset of severe pain redness and swelling in the inner corner of his eye. On examination, purulent discharge, erythema and induration on the lacrimal sac. Patient has history of chronic nasal congestion. We all know the chronic sinusitis can be one of the reasons of these inflammations and infection. So what is the diagnosis? It is a very, very simple question. A chronic dacryocystitis will not present with pain and tenderness. Dacryocystocele happens in a small child. That is mainly retention of the amniotic fluid. Canaliculitis, again it will not. Why not canaliculitis? There should be some pouting in the canalicula and other findings should be specifically mentioned, right? So I would go more towards the more common diagnosis, and this would be acute dacryocystitis. All the clinical presentation goes towards acute dacryocystitis. Yes, so this time you all are correct. Very nice. It is B. Yes, B is the answer. ठीक है? ये तो बहुत simple question था. Okay. And what is the most, chalo, answer karo, what is the most common cause of acute dacryocystitis? What will you answer? Most common cause of acute dacryocystitis. What should we answer here? Organism. I want to know the name of the organism, most common cause. And also, what is the sequelae of acute dacryocystitis? Answer me this. I'm waiting. Come on. Most common cause. So, this is again a case of acute dacryocystitis. If it is not treated on time, the sequelae can be lacrimal fistula. Okay, and remember this fistula is mainly on the skin. Okay, it opens on the skin. Lacrimal fistula. Nobody is answering? Okay, most common etiological agent, bacterial. Acha, pata hi nahi tha. So, am I intending to ask you this? अपना नाम नहीं रखो और ऐसे कुछ भी नाम रख लो ना तो फिर दिमाग भी ठीक नहीं चलता. Okay, this was just a slight mild joke. Please don't feel offended or anything. But tell me, what is bacterial? Am I expecting this or should I know the name of that bacteria? Why am I asking this? Huh? Jaldi batao. What? Full name GRS Narayan. Full name batao. Black Panther. फिर से सोचो. हाँ Nahid. Very good. It is Staph aureus. अब एक और चीज सुनो. Staph aureus is most common cause for both acute and chronic. Can you note down? For both acute and chronic, the most common. And please stop thinking that I don't have to study about most common anymore. It can be a part of your option. We have to study everything and we are already studying everything. There's nothing special we have to do. We just need to think differently, solve differently. Okay, we come to the next. I hope you didn't mind Black Panther. It was just a smile joke. Okay, so we come to the next question. फिर से हम last line पढ़ें. चलो, let's read. We are asking, it's asking the diagnosis. Okay, so this is your herpes simplex, Postner's Klausman, Fuchs heterochromic neovascular, glaucoma, uveitis, something like this. Okay, let's read the question. A 45-year-old male patient presented with gradual blurring and diminution of vision in his right eye. ठीक है, right eye में gradual blurring and diminution. On examination, right eye vision goes to 6/24. So, thanks. So, it goes to 6/24. Slit lamp examination shows, pay attention, this will help you in the answer. Slit lamp examination shows heterochromia iridis, stellate capes with mild flare and few cells. Stellate capes, heterochromia iridis and atrophic patches in the iris. Diagnostic of, I don't even have to read the full question. I know we are talking about Fuchs heterochromic cyclitis, isn't it? Lens may, do you all remember in this condition PSC is very common. So, lens has posterior subcapsular cataracts, left eye is normal, and on gonioscopy, small vessels in the angle. Do you all remember what did we call this? Amsler's sign. When you do a paracentesis, from one angle you see bleeding. That is what is Amsler's sign. We have already read all this. Okay, left eye is normal. Intraocular pressure is normal. So our answer here is Fuchs heterochromic cyclitis. So let's keep it. Why we have kept herpes simplex uveitis? That is also another uveitis where you get patchy iris atrophy. But other findings, and do we all remember Fuchs heterochromic is atypical anterior uveitis. क्या पढ़ा था? What is atypical? When the 5 signs, pain, redness, photophobia, blepharitis patch, this is not prominent. That is your atypical anti-uveitis. Which is the other atypical we read? Juvenile rheumatoid arthritis. So in these two, the anti-uveitis, the typical presentation is not present. The patient's eye is not even red. That's why even JRA uveitis is called white uveitis, isn't it? So when that is what is atypical anti-uveitis means, where redness, pain, photophobia, ye typical features nahi hai, it is not there. Then you call it atypical. And these are the two names you have to remember. One is Fuchs heterochromic cyclitis and second is your JRA. So that is why it is written, that is mild flare, few cells, right? If you see, it is all mentioned here. So, and we all know, if you quickly want to revise, what are the features of Fuchs heterochromic cyclitis. So this is the iris atrophy, and because of this iris atrophy, please remember no posterior synechia and stellate capes with feathery ends. It is described as with feathery ends. Then posterior subcapsular cataract. Okay. And of course, heterochromia iridis. That is very important. What do you see here? We are seeing bleeding on paracentesis, which is also seen on gonioscopy here. This is what is called Amsler's sign. This is what is Amsler's sign. Yes, Zeba. Okay. These are the features. Why it cannot be Posner's-Klossman? Pressures are very high in this condition. Is it a uveitis or a glaucoma, Posner's-Klossman? Chalo, we will think about it and in the further question. Chalo, come to the next question here. Again, I'll start with the same method which I suggested you. What is the last thing they are saying? Okay, I have not written it. It should be what is the diagnosis. Huh? So, what are the things I have to think about? Vitritis, endophthalmitis, panophthalmitis, vitreous hemorrhage. So, in that line, I am going to now read the question. I start with the question. 60 years old female presented to IOPD, complains of marked diminution of vision in her right eye. So, what is the right eye vision? Is only 6/60. There is severe pain, redness for watering. Very important, had undergone cataract surgery of her right eye for only 4 days back. And another important thing, on examination, right eye is this in contrast to the records of her visual acuity of 6/9. So, in the immediate post-op period, what does it mean? Immediate post-op, the vision was 6/9. After 4 days, the vision is 6/60. What is the answer? Very good, Nahid. Marked conjunctival congestion, chemosis, corneal haze, corneal edema होता है ना, hypopyon भी होता है. Very, very important diagnostic feature. Fundus glow is absent, right? So, ultrasound B scan is already showing you vitreous exudates. Yes, we are talking about acute onset endophthalmitis after cataract surgery. Okay? So, this is acute onset endophthalmitis. What is the most common cause of acute onset? I hope you remember, it is staph epidermidis. And late onset is propionibacterium acne. All the features of endophthalmitis you can learn from here. If you want to really put it in the diagram and see what this question says, it is saying there is corneal edema. It is saying that there is conjunctival congestion. You think in this term. Ophthalmology becomes very simple like this. Study in my style. Just make a simple diagram and start thinking this way. Okay. So, यहाँ पे vitreous exudates है ना? All the signs of anterior uveitis is here. Vision has gone down badly. There is hypopyon here, isn't it? No fundus is seen. So, we are talking about fundus glow is absent. We can't see it. So, we are talking about endophthalmitis. Okay, one more question before I go to the next one. Can you tell me what is one differentiating factor? Okay, Zeba, what is one differentiating factor between clinically, how will I know it's an endophthalmitis or is it a panophthalmitis? Chalo, batao. What is one clinical sign which will help me to differentiate between is it endophthalmitis or is it panophthalmitis? I'm waiting. Still confused. I want to know the. So Rahul, everything is a pros and cons. We can talk about both, है ना? And this is not the time to discuss that. The point here is whatever comes in your way, challenge it, fight it, and win. If something, what is in our hand is to do our best, right? Okay, nobody's answering, so let me answer this for you. That we are going to look at sclera. Somebody said sclera. So Nahid, what will be the clinical sign? Think like this, na? Scleral involvement hai, to clinical sign kya hoga? Ocular motility will be restricted. So if the ocular motility is restricted, then it has involved us. So restricted ocular motility means now we are talking about panophthalmitis. Okay? Chalo, we come to, this is a case with a mild hypopyon, corneal haze, conjunctival congestion. Ultrasound here shows vitreous exudate. This is what is vitreous exudates, and in this case even there seems to be retinal detachment. Okay, we come to the next question. Again the same method. What is the most probable diagnosis? What are the options? Marfan syndrome, homocystinuria, Wein-Marchesani, Ehlers-Danlos. So now your mind should go where? Very quickly, if you have read, if you have actually studied well, quickly you will start thinking about subluxation of lens, looking at these options. Now you read the question, it becomes very simple. A 28-year-old female patient presents in OPD with diminution of vision and glare in both eyes. Diminution of vision hai or glare hai? She is tall, thin stature, disproportionately long limbs and arachnodactyly. I think you already know the answer. On examination, visual acuity in right eye is 6/12, left is 6/18. Glasses used by the patient. Why we are looking at the glasses? What is this telling you? The patient is, padha hai na humne in Marfan's? There is axial myopia. So the patient is myopic with minus lenses she is using. Yes, we are talking about Marfan syndrome. And no anisocoria, no RAPD, that means the optic nerve part and everything is fine. Pressures are fine, slit lamp examination and oblique shows superior subluxation of lens. So sorry, superior subluxation of. Okay, so fundus is again normal. So yes, we are talking about Marfan. So Marfan's mein, what is the direction of subluxation? I think you know my method. How do I teach you? Marfan's ka M banao, and over the M you make a cap here. Make an arrow like this and this. So what is the direction of subluxation? It is superotemporal. So in Marfan's it is superotemporal. And in the same diagram, if anybody is listening for the first time, please draw this. In the same diagram, you can make a dotted line here and make an arrow and write here H. So this is my age-old method of teaching you all the direction. So M ka ye ho gaya superotemporal, make opposite dotted lines, write H. What is this? Homocystinuria. In homocystinuria, this is inferonasal. It is inferonasal. Wein-Marchesani or Marchesi is downwards and forwards. Ehlers-Danlos, no direction is mentioned. We generally learn it is superior. It is generally ectopia lentis and no direction is mentioned, so we don't have to learn it. Okay? Ehlers-Danlos, another important thing I always tell you here, blue sclera. What is blue sclera? Very thin sclera where the underlying uveal tissue is visible. That is what is called blue sclera. What are the other causes? I hope you all remember. Osteogenesis imperfecta, then pseudoxanthoma elasticum and so on, where the collagen disorders will make the sclera very thin and therefore the uveal tissue will be visible. Scleromalacia perforans, that is a scleritis which is necrotizing. Here also you can get a blue sclera. So these can be the causes if you want to note down. Osteogenesis imperfecta, pseudoxanthoma elasticum, what did I say? And of course Ehlers-Danlos bata diya, and scleromalacia perforans. See, this is very important. This is the golden crescent, which is a typical feature of lens subluxation, right? So in Marfan's, if I go back to Marfan's, what are the ocular features? Very quickly, I will write here. Think outside to in, because hands are long, fingers are long, eye is also long. So outside to in, first feature would be axial myopia. Okay. And then because of the stretching of the eyeball, cornea is large, so megalocornea. So megalocornea. Then of course superiotemporal ectopia lentis. And when there is more axial length, if you remember your retina chapter, you will get lattice degeneration and you may also get rhegmatogenous retinal detachment. So these can be some features of Marfan. So if you make the diagram, if you can see here, it becomes so easy to learn. Axial myopia, megalocornea, right? Ectopia lentis, lattice degeneration and rhegmatogenous RD. So blue sclera doesn't mean that sclera is blue in color. I hope you know this. Sclera is very thin and the underlying uveal tissue is visible. That is what is called blue sclera. Chalo, we come to the next question here. Again, I am going to look at the options. What is the most probable diagnosis? We are talking about glaucoma and cataract and uveitis. Okay, so let's try to understand the question. 55 years old male, please read it along with me, presents with complaints of blurred vision, discomfort and colored halos in his left eye. There are colored halos in the left eye, okay? Quickly think, colored halos to cataract ho sakta hai, it could be high pressures, isn't it? Or mucopurulent conjunctivitis. So there is the left eye colored halos. He gives history of similar episodes 5 years back. So it's a recurrent case. On examination of left eye, his intraocular pressure is 53. That's why colored halos. Can you see here? Right eye is okay. Slit lamp examination of left eye is showing edema, corneal edema, but only single, but there is a single KP and few aqueous cells. Is it a glaucoma or a uveitis? It is a uveitis where the pressures are more. Do you remember what are we talking about? Where there is uveitis with more pressures. Let's see further what is given in the question. Nuclear sclerotic changes in the lens are present. Okay, cataract ho raha hai. Iris is hypochromic with peripheral iridotomy ho chuki hai. That means this case has been confused with angle closure glaucoma and peripheral iridotomy has been done. And in spite of that, he is again getting the episodes of red eye. You understand? So, why? Because the diagnosis was not correct. This case is not a case of acute angle closure glaucoma. So, which is the condition which he is confused with? Yes, very good, Shubham. So, we are talking about glaucomatocyclitic crisis. That is your Posner-Schlossman syndrome. Okay? So, what should you answer, Shubham? A, B, C, D mein? If these are the options, what should we answer? The pupils are dilated and reacting sluggishly. See, sometimes you come to the diagnosis, you don't have to even read the question, but please don't do this mistake. Read the question fully twice before answering anything. Always make it a rule of the thumb that every question I will read twice before answering it. Chahe mujhe kitna bhi confidence kyun na. Okay? Also, right eye anterior segment shows mild nuclear sclerotic changes. On gonioscopy, both eyes angles are open, important. There is no angle closure glaucoma, angles are open. Fundoscopy, CD ratio is normal, okay, in both. And what is the most popular diagnosis? Yes, Shubham, so we will answer, it is, what is Posner-Schlossman is primarily a uveitis where pressures go very high as 53. इसीलिए इसमें जब treatment करते हैं, we give steroids but under anti-glaucoma cover. We will always first start with anti-glaucoma drugs, decrease the pressure, and then to control the uveitis we have to start steroids. Okay? So we are here talking about Posner-Schlossman syndrome, and Posner-Schlossman syndrome is also known as glaucomatocyclitic crisis. What is the third name? It can also be called hypertensive uveitis. Matlab, wo uveitis which increases the intraocular pressure. This is not uveitis with hypertension. That is different. When we say uveitis with hypertension, we are trying to tell you this is a patient of BP problem. There is hypertension and there is uveitis. But if I use the term hypertensive uveitis, इसका मतलब है hypertensive uveitis is hypertensive है, okay? That is that uveitis where pressures are more, that is we are talking about glaucomatocyclitic crisis. So Akshay, glaucoma, it's not primarily a glaucoma, it's primarily a uveitis. We see KPs, we are seeing aqueous cells. Pressures are raised, but there is angles are open. You understand? This is one condition where a uveitic attack is actually, this is HLA associated. It is a genetic condition. It generally happens in young males. Okay, look at the age. That's why young. This was important, and it may be etiology exactly is not known. It may be associated with either H. pylori infections or CMV infections. Keep that in mind. Okay, so that is why this is the mistake, na? That's why see peripheral iodotomy was ineffective. This is not glaucoma. We have to answer it as uveitis. Akshay, theek hai? Are you convinced? Let me know, please. So see, this is the patient. He was thought to be a patient of angle closure. Peripheral iodotomy was also done because the pressures were very high. There was a red eye. This was done. And what you would have given? Pilocarpine, that increases inflammation. So not a good idea to go. So, but actually this patient is a case of uveitis. That is why he is getting it again. The repeated attack even after peripheral iodotomy. Right? Okay. Not much is left. Okay, so this is your acute congestive glaucoma. If you see this patient, it's a red eye, corneal edema and so on. Mid-dilated vertically oval, mid-dilated pupil. Look at this one. It is not dilated at all. So this is the rule to always differentiate uveitis from glaucoma. Uveitis, the pupil is always constricted, and in angle closure, it is vertically oval, mid-dilated. Or just remember mid-dilated or vertically oval, mid-dilated pupil. Why do you say vertically oval? Do you know? It's a simple reason is whenever there is a dilatation of pupil, it always starts vertically oval and it stops at that stage. That's why you call it vertically oval. Okay, we come to the next question. Let's see. So the question can be asked in this way as well. Let us read it. Which of the following statements are true for chloroquine-induced toxicity? Do we know the ocular effects of chloroquine? Then we can answer this. First, it causes anterior subcapsular cataract. Is it correct or not correct? Answer this. Is it correct or not correct? Very good, Arun. So, this is not correct because it causes posterior subcapsular cataract. You remember toxic cataracts I taught you? BSC causes PSC. This is busulfan, steroids, chloroquine. So, busulfan, steroids, chloroquine. They cause posterior subcapsular cataract. Rest all will cause anterior subcapsular cataract. चलो, एक तो ये हो गया. दूसरा, it affects the macular bullseye maculopathy. Yes. Optic neuritis. Yes. And it causes vortex keratopathy. Yes. So answer is B. Akshay, what do you want to know? चलो, ऐसा करो. First you attend the lecture or you read about Posner-Schlossman syndrome and then we will discuss it further. You can just DM me what is your doubt. Okay? Okay. So this is your bullseye maculopathy. I hope you know it is alternate areas of hyper and hypo. Hyper is nothing but drug deposition and melanin pigmentation, and hypo is atrophy of the retinal pigment epithelium. This is how it looks like. It is important. This is bullseye maculopathy. Do you remember what are the causes? One is chloroquine. Another will be hydroxychloroquine. Then cone dystrophy, then Baton's disease. Now this is not very important. If you don't want to learn it, don't learn it. Last one, but first three you should know. This is your vortex keratopathy where drug is deposited in a whirl-like manner like this. This is what is also called cornea verticillata. We call it cornea verticillata. Okay? So cornea verticillata, this, what are the causes? Quickly let us revise together. One is chloroquine, then amiodarone, tamoxifen, Fabry's disease, isn't it? What else? Indomethacin. Right? So these are the drugs. And also remember, chlorpromazine is deposited on the endothelia, not on the epithelium. These are all epithelial deposits. Okay, vortex is epithelial deposit, but chlorpromazine is endothelial deposit. Okay, we come to this one. Let us look at this question again. Diagnosis. This is, we are going to follow like this. These are the cataracts. Okay, so we have to know the stage of cataract. The options is giving the idea. Look at them, how big the question is. So first, it's a smart decision always to look at the options. Okay, so a 59-year-old female patient presenting to the IPT with gradual diminution of vision. Okay, more in her right eye. She also complains of increasing difficulty with glare from bright lights at night, seeing road signs and in reading newspaper. The patient is hypertensive with type 2 diabetes. On examination, right eye visual acuity is hand, so it becomes hand movement, and left eye is finger count. Such a low visual acuity, it cannot be immature cataract, right? Pupils are round and reacting with IOP is normal in both eyes, anterior segment. Now here is the main crux. Right eye brunescent nucleus sclerosis, sunken inferiorly in the surrounding cortex. So simple. So we are talking about, yes, we are talking about Morgagnonian cataract, where this is what you have to know. Left eye also there is nucleus sclerosis and diffuse cortical changes. Fundus examination was not possible due to opaque media. You may not always be able to comment on fundus here, right? So ultrasound B scan. Why did we do ultrasound B scan here? I've taught you. Because when you're not able to see the fundus behind, you want to operate this patient. Manlo, you are saying, okay, I am operating your cataract, your vision will be fine, and he has some retinal pathology. You remove the cataract, his vision still is not fine. He's going to sue you. So you have to prognosticate the patient that, okay, when I'll do your cataract, how much is the chance that your vision improves? For that, I should know now, what is the condition of his retina? Therefore, if I can't see the fundus, at least I should go for a ultrasound B scan and look at behind to know is there any retinal detachment or any vitreous hemorrhage, anything. Okay? That is why this is given here. So our answer is Morgagnonian. Right? We all know this is a nuclear cataract. Nuclear cataract, what are the questions asked? Please remember, one question was, it is due to deposition of insoluble proteins and pigments. Which pigments? Mainly melanin and urochrome. Secondly, they have asked you about second sight of old age, that is improvement of near glasses. Please revise that, okay? That is improvement of near glasses is second sight. This happens because when there is a nucleus sclerosis, refractive index increases. है ना? So this is index myopia. Myopia कब बोलते हैं? When it is going towards more power. So it's a case of due to index myopia, because the refractive power of the lens will increase, therefore he will use lesser number on his specs. That is what is improvement of near glasses is called second sight of old age. If you want to again learn it more in detail, please just watch my earlier sessions. You will revise it nicely. Okay. So then we come to this one, Morgagnonian cataract. The question here they have asked you is most common complication. This is what they have asked you. And you should know it is phacolytic glaucoma, isn't it? Leakage of proteins blocking the trabecular meshwork, phacolytic glaucoma. Right. Come to the next question. So here let us look at this question. Most probable diagnosis it is asking, okay. And look at the options. Okay, different keratitis is main focus, which I can see. Right. So now let us think let us read the question together. A 39-year-old male patient presents with cloudy vision, photophobia and pain in his right eye since 3 weeks. Okay. The pain since then has increased 8 out of 10 on a pain scale. He is a contact lens wearer. I think we already got the hint. And at the time of presentation, he was given gatifloxacin and tobramycin eye drops every hour and cyclopentolate. Why do you give cyclopentolate? For associated uveitis, isn't it? In his right eye. But is there anything happening? Despite the therapy, ulcer was persisting and worsening. All the antibiotics given, it is not responding. It cannot be bacterial. right? On examination, and visual acuity is finger count in the right eye. So very low vision here. Yes, very good. You all are answering correct, but let's read the question. Ocular motility is full, intraocular pressure is normal, pupils round reacting. Corneal sensation in the right eye is decreased and left eye normal. Now comes right eye showing ring lesion on the cornea with hypopyon. So we cannot go with the decreased sensitivity is not always viral. You have to think of other things around you. Okay, few KPs are present, means there is associated uveitis as well. Enlarged corneal nerves. Why will that happen in acanthamoeba? Because it causes neuritis. Okay, so there can be enlargement of corneal nerves in acanthamoeba. So what is the diagnosis? If you know contact lens, history of contact lens with this, it is, and of course pain is disproportionately very large, and that's what we are saying, 8 out of 10 scale pain. So hence answer will be acanthamoeba keratitis. What are the quick questions here on acanthamoeba keratitis? Of course, history of contact lens is one thing they ask you. Then they have asked you about choice, drug of choice. Don't forget it is polyhexamethylene biconides. Then they have asked you about culture media. You will say non-nutrient agar with E. coli. Culture media, non-nutrient agar with E. coli. Okay. Yeah. And what is pathognomic of viral keratitis? Decreased corneal sensation. Okay. It's not absent. It is decreased again. Yes, Shubham. Very nice. Yes, it is radial neuritis, Shreya. You are also correct. Okay. So this is a ring lesion. We can see here, right? It's acanthamoeba. And this is again a ring with a hypopyon. The ring with a hypopyon. I think the earlier one is more clearer, but here we will look at the hypopyon. Okay, we come to the next question. So this one is the last question. So look at the options. So pay attention and look at the options here. Most probable diagnosis, mild NPDR, very mild. So now quickly you know that we have to find the staging of NPDR. This is the case of diabetic retinopathy. And which it could be PDR or NPDR or not? Okay, it is NPDR, all the 4 options. Yahan tak pata hai. Okay, let's solve. So 53-year-old male patient with gradual diminution of left eye more than right. ठीक है. Type 2 diabetes है, hypertension है, right? In the left eye vision is gone to 6/24. Slit lamp examination showing definitely changes होंगे. Diabetic cataract हो सकते हैं. Okay, left more than right. On examination, pay attention. There is multiple microaneurysms seen in both eyes in the macular area, but along with that, hard exudates are also there. So you have to be very, very thorough about the ETDRS classification of diabetic retinopathy. Again, I would like to refer my earlier sessions. Just go through it, what we have discussed in detail. But here also, let's answer. When it is only microaneurysm and nothing, we call it very mild. Okay, and along with microaneurysms, okay, this is very mild. There's one question, microaneurysms are seen in which layer? Please answer nerve fiber layer. In which layer? You will answer nerve fiber. And along with microaneurysms, if you get hemorrhages and exudates, as you can see it here, hard exudate, now it becomes mild NPDR, so your answer should be A. Okay, and you remember how we describe severe NPDR? Achha, before severe, first it is very mild, then mild. What is the next? It is moderate. Moderate NPDR means when you start getting additional features. Let's have a look, which will be easy. So this is the snowflake cataract or diabetic cataract this patient is developing. Correct? Now, this is the finding. He has both exudates as well as microaneurysm. Very important that you recognize what are hard and soft exudates. It has been very recently asked in your exam. Okay, so this is how these leaky lipids hard exudates look like, these yellow ones, right? And the hemorrhages. These look like, these are microaneurysms and this is exudates. Okay. Now, then we come to the next. We can actually differentiate very clearly. Suppose you confuse it with a dot and blot hemorrhage, then you have to do a fluorescein angiography, and hyperfluorescent dots, which are, these are mainly microaneurysms. So this is what we are looking here. Okay. The same here, microaneurysms. And this is the feature of moderate NPDR, where you are getting Your looping. What you're looking here, this arrow is showing you looping of the veins. This is what is looping of veins. Okay? Yeah. What are the other features? You can get intraretinal microvascular abnormalities, increased number of cotton wool spots, large blot hemorrhages. These are nothing but, these are venous infarcts. These are venous infarcts. Right? So, these are the findings. Okay. When it is proliferative, how do we know? Let's have a look here. So, what are you looking at? Your white arrow is showing you soft exudates. These are also called cotton wool spots. Right? The red arrow is showing you flame-shaped hemorrhages. Flame-shaped hemorrhages. And here you see green one showing you hard exudates. The green one is hard exudates. This is dot and blot hemorrhage, the blue arrow. And the black one is showing you, dhyan se dekho, these are the new vascularizations on the disc. So it is NVD. So actually it is a case of proliferative diabetic retinopathy. When you get all the features of non-proliferative along with new vascularization, it is proliferative. Right? Okay. So one more thing. How do you describe? I think one of you have answered correctly. Yes, Shubham. So when you say after moderate, that was moderate and severe NPDR, please don't forget and revise all of you what is 4:2:1 rule. So hemorrhage and microaneurysms in any 4 quadrant, or another criteria, looping and beading in 2 quadrants, or IRMA in 1 quadrant. And if anything more than one criteria is there, we call it very severe NPDR. 4:2:1 ka one criteria present hai, it is severe NPDR. More than one criteria is present, now it is called very severe NPDR. Okay, clear it? So yes, that was it. So all of you, it's absolutely very important to first come out of your fears and apprehensions. You all have the same potential. You all are very strong. You just have to tap your potential. Please remember that. And of course, you all should be knowing about the pro plan of PrepLadder. So the link is mentioned in the chat and you can go through that link and to the plan and understand more. So this is one place where you're getting 100% clinical questions, which are all next based and next oriented. So all the best, all of you. Any questions you all have before we finish? Yeah, thank you so much. Thank you for your appreciations. God bless you all. So okay, even if you want to ask anything, you can just directly DM me on the Insta. I will answer you, okay? Or you can just on the Messenger or Insta. So these are the 2 places I can be available, right? Or you can mail. Yeah, so thank you so much. All of you, stay blessed, all the best, work hard. And few FMG students are also